Welcome to Deep Dive Ortho, the show that cuts through the noise to give you the clearest, most actionable insights for your practice. Today, we're plunging into a condition that, well, for many of our patients, represents some of the most excruciating shoulder pain imaginable. We're talking about that intensely painful, often perplexing challenge, calcific tendonitis of the shoulder. For anyone in orthopedic practice, you know this pain. It's often spoken of in the same breath as a frozen shoulder, truly one of the worst pains in the shoulder. Our mission today is clear: to equip you, our mid-senior medical professionals, with a comprehensive, nuanced understanding of calcific tendonitis. We're going to unpack its etiology, pinpoint the diagnostic strategies, and explore the very latest in treatment approaches. This isn't just a refresher, it's a critical update designed to refine your patient management and sharpen your prognostic insights. And who better to guide us through this intricate landscape than our expert guest today? He's renowned for his ability to synthesize complex medical understanding into clear, practical knowledge, offering insights that truly bridge the gap between research and the clinic. Welcome.
Thank you. It's a genuine pleasure to be here and delve into a condition that, while common, still holds many, fascinating complexities for both patients and clinicians.
Okay, let's unpack this then. For those of us encountering calcific tendonitis in our clinics, what exactly is it at its core, and how prevalent is it in the general population?
Right. So, at its core, calcific tendonitis is fundamentally the pathological deposition of calcium hydroxyapatite crystals. These are laid down within the rotator cuff tendons. Now, while any of the four tendons can theoretically be affected, it's overwhelmingly the supraspinatus tendon that's the most common site. We're talking mainly about calcium phosphate crystals here. The problem arises because this deposition, it leads to a significant buildup of pressure within the confined space of the tendon itself.
Mhm.
And crucially, it causes substantial chemical irritation.
Hmm.
Both of these factors, the pressure and the chemical irritation, are major contributors to the intense pain patients experience.
So it's not just the physical presence of the calcium.
Exactly. There's a potent inflammatory component driven by these chemical processes.
Yeah.
This is particularly true during the resorptive phase, which we'll definitely get into more detail on later. Now, in terms of its prevalence, it's far from rare. Historically, based on plain radiographic observations, it was estimated to affect maybe between 2.7% and 10.3% of adults, in the general population, that is. But this figure has been significantly updated. The advent of newer, much higher resolution ultrasound technology has really changed the picture.
Okay.
Modern ultrasound is just far more sensitive at detecting even tiny calcific deposits, and has revealed a much higher true prevalence. For instance, some recent studies using this high-resolution ultrasound have shown prevalence rates as high as 17.1% to even 24.4% in female populations.
Wow, that's quite a jump.
It is. It really suggests we may have been underdiagnosing it quite significantly in the past, simply because we couldn't see the smaller deposits as easily.
Demographically, it certainly shows a clear predilection. It affects women approximately twice as often as men, and it typically presents in individuals aged between, say, 30 and 60 years. The peak incidence is often around 40 to 50 years old. While it's most commonly unilateral, affecting just one shoulder, it's really important to remember that about 10% to 25% of cases are actually bilateral.
Yes, both shoulders, sometimes concurrently, sometimes one after the other. It really adds to the patient's burden, as you can imagine. And as I mentioned, the supraspinatus tendon is overwhelmingly the most involved site. We're talking a vast majority, somewhere between 51.5% and maybe 90% of cases, depending on the study. But we shouldn't overlook the others. The infraspinatus and subscapularis can also be involved. Some more recent studies even suggest infraspinatus involvement could be nearly 50% and subscapularis around 33% in specific groups. So a comprehensive assessment is key. Now, crucial point for clinicians to remember, despite the often severe pain it causes, is that calcific tendonitis is fundamentally a self-limiting disease.
Self-limiting. That's interesting given the pain levels.
It is. It's a key insight. In many instances, these calcific deposits can and do resolve spontaneously over a period. Typically, this ranges from maybe 5 to 10 years. The challenge, of course, is that many patients remain highly symptomatic, really quite debilitated, during this prolonged natural course. And that's why intervention is so often necessary, even knowing it's technically self-limiting. Our goal is really to relieve their symptoms and restore function while nature, takes its course in the background.
That's a significant prevalence, especially with the newer imaging picking up more cases. A vital reminder that what we see clinically might just be the tip of the iceberg. What's truly fascinating here, though, is the underlying cause. Is it purely degenerative, sort of wear and tear, or are there other more active mechanisms at play? Could you elaborate on the different theories regarding its development?
Yes, this is where our understanding has really evolved quite dramatically. Historically, the older theory, going back to Codman and Akerson in 1931, proposed a degenerative calcification. This theory suggested that age-related degenerative changes things like decreased vascularization, localized hypoxia, eventual tendon necrosis would lead to the calcification.
Okay, that sounds plausible initially.
It does, but it struggled to explain two key observations. Firstly, why the peak incidence is in younger adults, typically those 30 to 50-year-olds, not the elderly. And secondly, and perhaps more crucially, why it's a self-limiting condition. If it were purely degenerative, you'd expect it to be a progressive, irreversible process, wouldn't you?
That makes sense, yes. Degeneration doesn't usually just stop and reverse.
Exactly. So the more widely accepted theory today, the dominant one really, which better explains the clinical picture, is the reactive calcification theory. This was put forward by Uthoff and Lohr in 1997. This theory describes a dynamic cell-mediated process involving several distinct stages. And this model aligns perfectly with the fluctuating symptoms and the potential for spontaneous resolution that we actually see in patients. We typically describe three main stages, though some models add a fourth, sort of focusing on the post-resorption healing phase. First, we have the precalcific stage. This stage is characterized by something called fibrocartilaginous metaplasia of the tendon.
Metaplasia.
Yes. Essentially, the normal tendon cells, the tenocytes, they begin to transform. They change their phenotype into chondrocytes, which are cartilage-producing cells. It's a crucial transformation. Importantly, this stage is typically pain-free and clinically silent. So patients are usually completely unaware they're even in this phase.
Right, so it's happening under the radar initially.
Precisely. Then comes the calcific stage. And this is further subdivided into three crucial phases, each with quite distinct clinical implications. First is the formative phase. Here, cell-mediated calcific deposits actively form and grow within the tendon. During this phase, patients may or may not experience pain. Radiographically, these deposits often appear quite well circumscribed and dense.
And what's the consistency like?
Typically described as chalk-like, during surgical debridement, hard and granular. Next is the resting phase. This is sort of quiescent period. The calcific deposits are present, but there's a notable lack of significant inflammation or vascular infiltration around them. Similar to the formative phase, pain may or may not be present. If it is, it's typically more chronic, intermittent, and generally less severe than in the next phase. These also tend to be the chalk-like deposits. And then we have the resorptive phase. Now, clinically, this is the most significant and often the most painful phase. This is the one that usually brings patients into our clinics, often in acute distress.
This is the really bad pain phase.
Yes. It's characterized by intense phagocytic resorption of the calcium deposits. Cells like macrophages and giant cells actively work to break down and remove the calcium. This whole process is accompanied by marked inflammation and vascular infiltration, which directly contributes to the pain. It's during this phase that patients often present with that acute, excruciating pain. It can be sudden in onset, severe enough to disrupt sleep and daily activities completely.
And the consistency here is different.
Very different. On arthroscopy, these deposits are often described as having a toothpaste-like consistency, soft, creamy, easily extruded. It's the hallmark of acute calcific tendonitis. And finally, there's the post-calcific stage. This involves the gradual resorption of any remaining deposits, followed by the healing and remodeling of the tendon tissue itself. The spaces where the calcium was are replaced by granular tissue, and the tendon begins to return towards its normal structure. It's quite a testament to the body's healing capacity, actually.
That clear breakdown of the stages really helps us understand this dynamic, cell-mediated process you've described. It makes so much sense why it's not simply degenerative. But to truly appreciate its intricacies, could you take us a step deeper? What's happening at the cellular and molecular level? Are there particular pathways or cell types central to this transformation?
Absolutely. We've covered the macroscopic stages and the main theories. But underpinning all this is a fascinating biochemical dance. At the core, as we mentioned, it involves the deposition of these calcium hydroxyapatite crystals. Research has identified key molecular pathways that play a role in this, well, abnormal mineralization. Things like osteopontin, cathepsin K, and transglutaminase 2. These molecules are intricate players involved in mineralization, collagen organization, tissue remodeling.
Complex stuff.
Very. Osteopontin, for instance, is a glycoprotein that regulates mineralization. Cathepsin K is an enzyme involved in bone resorption. Their aberrant expression or activity seems to contribute to the pathological calcium deposition. What's truly fascinating, though, and an emerging area of understanding that's really shifting our perspective, is the critical role of tendon stem cells, or TSCs.
Ah, the stem cell.
Yes. The prevailing evidence now suggests that calcific tendinopathy might actually be a failed cell-mediated healing process. See, normally after an injury or microtrauma, TSCs are crucial for tendon repair. They differentiate into tenocytes, the normal functional tendon cells. However, in the presence of altered local conditions, and this is key things like excessive mechanical loading, chronic microinjuries, maybe changes in the local biomechanical environment like hypoxia.
So the environment changes their behavior.
Exactly. These TSCs can aberrantly differentiate. Instead of becoming healthy tenocytes, they transform into chondrocytes, the cartilage-producing cells, or even osteoblasts, which are bone-forming cells. This altered differentiation, likely mediated through mechanisms involving prostaglandins, particularly prostaglandin E2, leads to chondrometaplasia, abnormal cartilage formation in the tendon and subsequently ossification, bone formation where it shouldn't be.
Right, yeah.
This creates an aberrant extracellular matrix and results in those calcific deposits we see. So it's not just inert stuff appearing, it's a deviation from the normal healing pathway, sort of misdirection of the body's own repair mechanisms.
That's a much more active process than just deposits forming. Okay, so what systemic or external factors do we know contribute to this? What predisposes someone?
Good question. There are several noteworthy contributing factors and associations that clinicians should definitely be aware of. Firstly, endocrine disorders show a strong association. Diabetes is a significant risk factor. Over 30% of insulin-dependent diabetics have been reported to have tendon calcifications.
30%, that's high.
It is. The hypothesis is that chronic high glucose levels can lead to glycosylation of matrix proteins in the tendon. This alters the structure and function of the extracellular matrix and can negatively impact the niche of those TSCs, making them more prone to this aberrant differentiation. Hypothyroidism is another one, strongly linked, with prevalence rates up to 48% in some studies.
Wow.
And patients with either diabetes or hypothyroidism often experience an earlier onset of symptoms, a longer natural history of the disease, and importantly, a greater likelihood of needing surgical intervention compared to the general population. So, always worth asking about these.
Definitely. What about lifestyle or work?
Yes, occupational risk is also recognized. People whose work requires extended use of the arms in internal rotation and slight abduction, think desk workers, cashiers, assembly line workers, even dentists perhaps.
That prolonged posture.
Exactly. It can lead to an ischemic, hypovascular critical zone in the supraspinatus tendon, usually just medial to its insertion on the greater tuberosity. This reduced blood flow and oxygenation creates a local environment conducive to those aberrant cellular changes and calcification we discussed. A classic example of biomechanics interacting with cell biology.
And genetics, you mentioned that earlier.
Yes, there's a growing and increasingly compelling body of evidence supporting a genetic predisposition. An increased frequency of the human leukocyte antigen serotype class A1, HLA-A1, has been observed, suggesting a link to immune responses or tissue repair perhaps. But even more compelling evidence comes from murine models, from mice. Mice with a mutation in the ANK gene. ANK developed widespread mineral deposition.
ANK, what does that do?
It codes for a protein essential for transporting inorganic pyrophosphate, or PPI, out of cells. PPI is a major natural inhibitor of calcification, so if you have less PPI outside the cell, you create an environment highly favorable for crystal deposition. And the human ANK protein is nearly identical. Furthermore, studies on rotator cuff tear arthropathy have linked it with mutations in both ANK and TNA genes. TNP actually breaks down PPI.
So mutations in either could lead to less PPI and more calcification.
That's the thinking. Mutations altering extracellular PPI concentrations seem implicated in promoting calcium crystal deposition. While the direct role of ANK specifically in just rotator cuff calcific tendonitis is still being fully pinned down, these genetic insights are really paving the way for a deeper understanding. And they open up exciting possibilities for future targeted biological therapies, maybe even preventative strategies based on genetic screening someday.
That's a truly comprehensive picture of the underlying mechanisms, far more complex than simple wear and tear indeed. You've given us a glimpse into that dramatic clinical presentation during the resorptive phase. Now, let's translate that micro-level chaos into what we as clinicians actually see and hear from our patients. Can you describe that archetypal presentation? What's the patient narrative that should immediately trigger our suspicion, and what should we look for during a physical exam?
Indeed. The clinical presentation is often quite dramatic, particularly during that intensely painful resorptive phase. The hallmark symptom is atraumatic pain.
Knew a specific injury beforehand.
Usually not. It typically occurs without any specific preceding injury, and this pain can be acutely severe, often described as stabbing, searing, sharp. It's notoriously worse at night, making it incredibly difficult for patients to lie on the affected side. Many patients, because the onset is sudden and the pain is so intense, so disabling, will actually present to emergency departments, to A&E.
I can imagine.
And this sometimes leads to misdiagnoses. It can be confused with other acute shoulder conditions, acute bursitis, an acute rotator cuff tear, even septic arthritis, sometimes because there can be associated local heat and redness. So a careful differential diagnosis is essential. Beyond the pain, patients often report mechanical symptoms, things like catching sensations, crepitus, that grinding or crackling sound or feeling, and sometimes a true mechanical block, suggesting interference with normal shoulder movement.
Similar to impingement.
Yes, these symptoms can be quite similar to those of subacromial impingement syndrome, which is a common diagnostic challenge. To try and get comfortable, patients might consciously adopt a posture of internal rotation and adduction of the shoulder, trying to offload that inflamed tendon. They might also complain of muscle spasm around the shoulder girdle. During a physical examination, you'll typically observe a significantly decreased active range of motion, often severely limited simply due to pain. We might also identify scapular dyskinesia, where the scapula doesn't move smoothly or symmetrically with the arm. That can further contribute to the shoulder dysfunction and impingement. Naturally, subacromial impingement signs like Neer's or Hawkins-Kennedy tests will often be positive. In some chronic cases, you might even note supraspinatus fossa muscle atrophy, reflecting prolonged disuse or, much more rarely, some neurological involvement. Given the pain, it can sometimes be difficult to get a full assessment, so gentle handling is absolutely key. Now, here's a critical point for clinicians. Not all calcific deposits are symptomatic.
Right, the incidental findings.
Exactly. It's vital to make this distinction to avoid overtreatment. A significant proportion, somewhere between 2.7% and maybe 20% of patients, can be entirely asymptomatic. The deposits are just discovered incidentally on imaging, done for other reasons, maybe a chest x-ray or a scan for neck pain. However, a crucial caveat, 35% to 45% of these inadvertently discovered cases may eventually develop shoulder pain over time, so they're not entirely benign. Furthermore, it's been consistently observed that small calcifications, those less than about 1 centimeter in diameter, don't always correlate with pain.
Size matters then.
Size matters, but also appearance. Symptoms are most likely to present when calcifications are larger, generally greater than 1.5 centimeters in diameter, or, importantly, when they appear fragmented on imaging or show increased vascularity, a positive Doppler signal on ultrasound.
Indicating that resorptive phase again.
Precisely. It indicates an intensely inflammatory resorptive phase. So the mere presence of a deposit doesn't automatically explain the patient's pain. Its characteristics, its consistency, its activity, if you like, are paramount.
That distinction between symptomatic and asymptomatic cases and the nuances of the clinical picture are so important for avoiding overtreatment and correctly identifying the phase. Okay, so once we have that clinical suspicion, what imaging modalities are essential for confirming the diagnosis and guiding our management plan? And what specific features should we be looking for, especially thinking about those classification systems you touched on?
Right, imaging.
Yeah.
Well, plain radiographs X-rays remain the gold standard and the first-line diagnostic tool for calcific tendonitis. They're widely available, cost-effective, and give us crucial initial information. The essential views include an AP, or antero-posterior view, taken with the arm in neutral, internal, and external rotation, plus a supraspinatus outlet view and an axillary view.
Why all those different rotations?
These orthogonal views are crucial for precisely locating the calcium deposits in 3 dimensions, relative to the acromion and the humeral head. Typically, you'll see these deposits about 1 to 1.5 centimeters from the supraspinatus tendon insertion on the greater tuberosity. The internal rotation view is particularly good for seeing infraspinatus and teres minor calcifications. External rotation helps delineate subscapularis calcifications. X-rays are invaluable not just for initial diagnosis, but also for monitoring progression over time, assessing the location, density, extent, and importantly, the delineation, how sharp or fuzzy the edges are.
Yeah.
Now, you asked about the morphological classifications from radiography. There are several, and each has its historical significance. But for practical clinical application, the key is understanding how they reflect the disease phase and guide management.
Okay, what are the main ones?
Well, De Palma and Kruper's 1961 classification is very useful. It divides them into 2 types, which predict consistency and response quite well. Type 1 has a fluffy, ill-defined margin, often cloud-like. This typically signals the acute, highly painful resorptive phase, that's the toothpaste-like calcium, often responds well to barbotage. Type 2 is homogeneously dense with well-defined sharp margins. These are usually seen in the formative or resting phase. Less pain or chronic intermittent pain. This is the chalk-like stuff, harder, more granular, more resistant to aspiration.
So fluffy versus dense is a key visual cue.
It really is.
Hmm.
Then Gertner and Heyer in 1995 gave a slightly more nuanced three-type classification, also predicting the phase. Type I is well-circumscribed, dense, formative. Type 2 is softer contradense or sharp transparent, transitional maybe. Type 3 is translucent, cloudy, no clear boundary that's highly indicative of the resorptive phase, the acute pain. And the French Arthroscopic Society classification, Mollet et al., 1993, refines this further into 4 types, A to D, with similar correlations. Type A is dense, sharp, formative, resting. B is dense, segmented. C is heterogeneous, soft, resorptive. And D is dystrophic calcifications right at the insertion, often with degeneration.
So many classifications.
There are. But for a busy clinician, the core takeaway isn't necessarily memorizing every type. It's understanding that fundamental distinction. Is the calcium toothpaste-like or chalk-like? That consistency, which you infer from the radiographic appearance, is probably the strongest predictor of how easily it can be aspirated or how it will respond to non-surgical treatment like barbotage. Understanding the resorptive phases, soft, acute deposits, versus the formative, fasting phases, dense, chronic ones, that's your really actionable intel from the X-ray.
That simplifies it nicely. What about ultrasound? You mentioned its increased use.
Yes, ultrasound US is now highly instrumental, increasingly seen as complementary to plain X-rays. It's useful not just for diagnosis, but also for precise localization, quantifying the extent, and assessing its vascularity via Doppler. Deposits appear as bright, hyperechoic areas on ultrasound, often with that characteristic posterior acoustic shadowing behind them. And modern high-res machines can detect incredibly small deposits, down to 300 micrometers, which is why they revealed that much higher prevalence we talked about.
And it guides procedures, too.
Absolutely. Ultrasound is invaluable for dynamically assessing the shoulder during movement and, critically, for guiding interventional procedures like needle lavage or barbotage and injections. It allows direct visual guidance right into the deposit. There are also US-based classifications. Chiodo described 5 types: arc shape, fragmented, punctuated, nodular, cystic. They notably found that fragmented deposits, especially with a positive Doppler signal indicating increased blood flow, strongly correlated with pain. Again, pointing to that active resorption driving symptoms.
Yeah.
Sansonio refined this with terms like granular, nodular, linear. These help us understand the calcium's activity, not just its presence.
Okay, so X-ray and ultrasound are the mainstays. What about MRI?
MRI offers excellent soft tissue contrast and multiplanar imaging, but its direct utility for diagnosing the calcific tendonitis itself is actually limited. Why is that? Because calcific deposits typically appear as low signal intensity on all MRI sequences. They're just dark spots. This makes them difficult to reliably distinguish from other things that cause low signal, like artifacts from tissue interfaces or even hemorrhage. However, MRI becomes crucial when assessing for concomitant pathology, things that might be contributing to symptoms or altering the treatment plan.
Such as?
Identifying rotator cuff tears, greater tuberosity osteolysis, that's bone erosion due to the calcification or surrounding edema. It's particularly useful in complex cases with refractory pain, or when surgical planning requires a full picture of the surrounding soft tissues. But it's higher cost, potential tolerance issues for some patients. It's not usually the first-line diagnostic for the calcification itself.
And CT scans.
CT scans are rarely required for routine diagnosis. They might be useful for characterizing the 3D bone anatomy in very specific, complex scenarios, maybe prior to revision surgery or if unusual bone remodeling is suspected. They offer superior bone detail compared to MRI, but usually aren't needed here.
That's a really helpful deep dive into the diagnostic arsenal, helping us pinpoint what we're looking at and why certain modalities are preferred.
Okay, so we've diagnosed it, we understand its dynamic nature. What does the evidence tell us about the initial approach to treatment? Where do we begin, and what are the cornerstones of conservative management, especially considering that fluctuating pain?
Right, treatment. Conservative measures are unequivocally the first-line choice for patients across all phases, really, particularly for initial symptom control. The reported symptom resolution rates with conservative management are actually quite encouraging. Somewhere between 60% to 70% of patients experience significant relief or complete resolution after about 6 months.
That's pretty good. It is. But it's important to set realistic expectations. We need to recognize that the probability of conservative treatment failing is higher with bilateral calcifications, very large deposits, usually those bigger than 1.5 centimeters, or if the deposits are situated under the anterior third of the acromion or extending medially into the subacromial space where they can cause more mechanical impingement. So the core conservative strategies typically involve a few key things. First, NSAIDs and rest. Non-steroidal anti-inflammatory drugs are the most commonly used pharmacological agents in the acute phases. They help relieve pain and reduce inflammation, especially during that awful resorptive phase. They can be crucial for breaking that acute pain cycle.
But with caveats, presumably.
Absolutely. Clinicians must exercise caution. Review the patient's medical history thoroughly. Any history of GI issues like ulcers, renal impairment, cardiac disease, given the potential side effects. Short courses are often preferred. Rest of the affected shoulder, maybe a brief period in an arm sling, is also crucial for initial pain management, allowing that acute inflammation to settle. Interestingly, some older, smaller studies explored less conventional things. One even showed some efficacy for cimetidine, a histamine blocker, but the mechanism's unclear and it needs much more research, not routine practice at all.
Right. What else in the conservative toolkit?
Physical therapy, PT, or physio. This is absolutely essential. Primarily aimed at preventing stiffness, restoring full range of motion, and strengthening the shoulder muscles. Therapists focus on a progressive program. In the acute painful phase, it's often about gentle, passive range of motion, like pendulum exercises, to maintain mobility without flaring things up. As pain subsides, the focus shifts. Active assisted, then active range of motion, eventually progressing to strengthening exercises for the rotator cuff and scapular stabilizers. Restoring normal scapular mechanics is particularly important, as dyskinesia can contribute to secondary impingement. The goal is gradual return to full, pain-free function.
And injections.
Corticosteroids?
Yes, corticosteroid injections.
Yeah.
Commonly used often into the subacromial bursa to manage acute pain, reduce bursitis inflammation, or alleviate impingement symptoms. They can provide very rapid, though often temporary pain relief.
But controversial, you said.
Somewhat, yes. While they can be effective for short-term symptom relief, some evidence suggests they might have no long-term benefit, or even a negative effect by potentially interrupting that natural calcium reabsorption process, maybe prolonging the disease course. The benefits are often variable in duration, and repeated injections aren't generally recommended due to potential tendon weakening. So their use is typically reserved for severe acute flare-ups unresponsive to NSAIDs and rest, or perhaps to facilitate starting physical therapy by calming things down initially.
Those conservative measures are indeed the bedrock, and it's clear we need to be mindful of their limitations. What about those persistent cases, the patients who aren't getting enough relief with painkillers and physio, or who simply can't wait years for natural resolution? This is where it gets more complex, looking at more targeted, minimally invasive interventions. How do we choose?
Precisely. For those patients with persistent symptomatic calcific tendonitis that hasn't responded to a decent trial of conservative approaches, say, at least 3 to 6 months, we then consider these minimally invasive procedures. They aim to either break down or remove the calcium or stimulate the body's own resorption processes. One of the most effective and commonly employed is ultrasound-guided needle lavage, also widely known as barbotage.
Barbotage, okay.
Indications. It's particularly useful for persistent symptomatic cases, especially when the deposit is in that acutely painful resorptive phase. Remember, that's when the calcium has the softer, toothpaste-like consistency, making it easier to aspirate. It's generally less effective for the dense, chalk-like deposits of the formative resting phases. Technique. It involves using either 1 or 2 needles under direct ultrasound guidance for precision and safety. With a single needle, you inject a bit of saline, often with local anesthetic, right into the calcification, then release the plunger pressure to allow the calcific stuff to flow back into the syringe, trying to break it up and suck out as much as possible. The 2-needle technique uses 1 needle to introduce saline local, while the other aspirates creating a sort of continuous lavage or washout system.
Sounds like it could be uncomfortable.
It can be, yes. It's common practice to follow it with a corticosteroid injection into the subacromial bursa to prevent post-procedural bursitis and inflammation, which can be significant initially. Patients should definitely be warned about a possible transient flare-up of symptoms for a day or 2 afterwards due to the inflammatory reaction, but it's generally well tolerated with good local anesthetic and post-procedure painkillers. Outcomes. Studies consistently report good short to mid-term results. Some show excellent outcomes at up to 73% of cases, often correlating with a significant reduction or disappearance of the calcium on follow-up imaging. It tends to work better in those Gertner type 2 or 3 deposits, the softer, more fragmented ones. Long-term efficacy still needs more large-scale studies, but it's a highly effective option.
Okay, barbitage for the softer acute deposits. What else? Shockwave therapy.
Yes, extracorporeal shockwave therapy, ESWT. Another significant non-operative option, indications. ESWT is a valuable adjunct, particularly useful for refractory calcific tendonitis. Interestingly, unlike barbitage, it's often considered more effective in the formative and resting phases, where the deposits are denser and less amenable to simple aspiration. It can also be used as a primary treatment, or if barbitage fails. Modalities and outcomes. It can be delivered as high-energy or low-energy therapy. High energy generally shows superior clinical outcomes and higher rates of calcium resorption, but it's associated with more procedural pain, sometimes needing local anesthesia and maybe local reactions like bruising. Low energy is less painful, often doesn't need anesthesia, but might require more treatment sessions.
How does it actually work?
The proposed mechanism is quite fascinating. The shock waves are thought to induce a sort of controlled microtrauma within the tendon, stimulating a biological response. This includes stimulating neoangiogenesis, new blood vessel formation, improving blood flow to that often hypovascular critical zone. It also increases local production of anti-inflammatory cytokines and growth factors. This leads to cell proliferation and, ultimately, a cell-mediated reabsorption of the calcifications. It essentially kickstarts the body's natural healing and remodeling process. Usually involves 3 to 5 sessions, maybe weekly or biweekly. Contraindications include pregnancy, pacemakers, coagulation disorders, local infections. Comparative efficacy. Studies comparing ESWT with ultrasound-guided needling, GLGN, like barbitage, have often shown UGN gets better radiological and clinical results, especially for those acute resorptive calcifications. However, combining ESWT and UGN has shown even greater efficacy than ESWT alone, suggesting maybe a synergistic effect. And importantly, some compelling research suggests ESWT can be as effective as surgical treatment for functional improvement and pain reduction, particularly for heterogeneous calcification types. So it's a very attractive, non-invasive option to consider before jumping to surgery.
Interesting. What about PRP, platelet-rich plasma? We hear a lot about that.
Yes, platelet-rich plasma, PRP, therapy. Rationale. The biological basis is to deliver supraphysiological concentrations of growth factors and other bioactive molecules, cytokines, chemokines, right to the target area, prepared from the patient's own blood, concentrated, then injected. The goal is to promote tissue repair and regeneration by boosting the body's own reparative cells, enhancing the natural healing cascade. Current evidence. Well, while the potential of PRP is promising for various musculoskeletal repairs, the evidence specifically for calcific tendonitis remains quite limited and, frankly, somewhat conflicting.
Why is that?
Often due to wide variations in how the PRP is prepared across studies. You get leukocyte-rich, leukocyte-poor, different platelet concentrations. Without standardization, comparing studies is difficult, like comparing apples and oranges. Currently, there's really only one case study, level V evidence, the lowest level reporting positive results for calcific tendonitis, showing complete radiographic disappearance in one patient.
So not strong evidence yet.
Not strong evidence specifically for this condition, no. While it's an exciting biological approach, aligning with that failed healing theory, we really need more robust prospective randomized controlled trials to validate its efficacy here before it becomes mainstream. It's an active research area, definitely.
Okay. And briefly, therapeutic ultrasound.
Yes, ultrasound therapy. This is the therapeutic application, different from diagnostic US. Some studies show that therapeutic ultrasound, often used with physio, can improve quality of life and relieve pain. The proposed mechanism involves microstreaming and cavitation physical effects, influencing cellular activity, enhancing local circulation, potentially speeding up natural resorption. Its effects have even been found similar to surgery in some contexts for pain relief and function. So it's a truly non-invasive option, good perhaps for managing chronic pain or as an adjunct, well-tolerated, good for patients wanting a gentle, non-drug approach.
That's an excellent and incredibly detailed overview of the non-surgical and minimally invasive options. It really highlights tailoring treatment to the patient's phase and the calcium's characteristics. But when those options aren't enough, when patients continue to suffer debilitating symptoms, surgical intervention becomes necessary. What are the key indications for surgery? What approaches are used? And what about those concomitant procedures like cuff repair or acromioplasty?
Right, surgery. When conservative and minimally invasive treatments have been exhausted and a patient continues to experience profound, progressive symptoms, Surgical decompression of the calcium deposit becomes an important consideration. The main indications are patients with severe symptoms refractory to non-op treatments for more than 6 months, or when symptoms significantly interfere with daily living, causing substantial functional decline, can't sleep, can't do essential tasks. It's important to note, only about 10% of patients with calcific tendonitis will ultimately need surgery, and the best effects are typically seen in chronic cases, symptoms over a year, well established. It's not a first-line fix. It's generally reserved for treatment failures.
And the approach is usually arthroscopic now.
Yes, arthroscopic surgery is universally the preferred technique today. It offers significant advantages over older mini-open approaches. Fewer morbidity rates, shorter rehab, better cosmetic results. Plus, crucially, arthroscopy allows a thorough look at the glenohumeral joint and the whole subacromial space. This lets the surgeon identify and treat any concomitant issues, a frozen shoulder, adhesive capsulitis, associated cuff tears, all in the same procedure. A comprehensive solution.
And the technique for removing the calcium itself.
It involves visually identifying the deposits through the scope. As we said in the acute or resorptive phase, it's often soft, toothpaste-like, easily extruded or aspirated. In chronic formative phases, it's chalk-like, gritty, firmer, needs more active mechanical removal. A key point for surgeons. Complete removal isn't always necessary and can risk excessive damage to the surrounding cuff tendon, potentially causing a defect or tear.
So you don't have to get every last speck out.
Not necessarily. The primary goal and effective mechanism is often decompression and mechanical disruption of the deposit, rather than absolute eradication. Even partial removal can trigger the body's natural resorption process and relieve symptoms. Typically, a probe or scalpel incises the tendon longitudinally over the deposit, letting the calcium be debrided and removed. A shaver can then remove residual fragments and inflamed bursa.
Okay. Now, what about those concomitant procedures, rotator cuff repair?
This is an area with nuances and debate. Whether to repair a resulting tendon defect after calcium removal, well, for small tears or defects, say less than 2 centimeters or less than 70% thickness, repair is often not required.
Why not?
Well, calcific tendonitis is self-limiting, remember. Progression of these small tears, specifically due to calcium removal, is relatively rare. The tendon often heals spontaneously. However, for medium to large, full-thickness tears, over 1 centimeter, or significant tendon defects resulting from removal or pre-existing, a repair might be performed. Side-to-side sutures for musculotendinous junction defects, or anchors for insertional tears. The main argument for repairing larger defects is it might allow earlier, more aggressive post-op rehab, which helps recovery and potentially reduces further tear risk. But some studies show no significant long-term difference in outcomes whether small defects are repaired or just decompressed. The body's healing response is often robust. It's a balance.
And acromioplasty, shaving the bone.
Subacromial decompression, or acromioplasty, is not universally required. It's indicated only if there are clear pre-existing signs of subacromial impingement, prominent bone spurs on the acromion, a type 2 or 3 acromial shape, obvious rough thickening of the coracoacromial ligament causing irritation. It could also be considered if a huge deposit can't be fully removed without risking tendon damage, as it decompresses base. But while older studies suggested it might help resorption, more recent literature indicates outcomes are substantially similar whether it's done or not, unless there's clear pre-existing impingement. So, definitely not routine.
And complications.
As with any surgery, recurrence of the calcium is possible if the underlying biology persists or removal was incomplete. Persistent shoulder pain can occur, maybe due to incomplete removal, residual inflammation, or other issues. Shoulder stiffness, adhesive capsulitis, is a significant concern if rehab isn't prompt or adequate, and rarely iatrogenic injury to the cuff itself during the procedure. Careful technique is paramount.
That's a thorough breakdown of the surgical side, and it's clear clinical judgment supported by a deep understanding is key. Surgery isn't the end, though. Proper rehab is absolutely key. What does the typical post-op rehab protocol look like? And importantly, what patient expectations should we be setting?
Rehabilitation is, as you rightly say, absolutely critical, and the protocol depends heavily on whether a rotator cuff repair was done alongside the decompression. For patients with calcific decompression only, no cuff repair, rehab can be quite accelerated. Focus on early motion to prevent stiffness. Immediate shoulder and elbow motion allowed as pain tolerates. We typically suggest a sling for protection for maybe 1 to 3 weeks, mainly for comfort and to stop accidental movements, especially at night. Passive and active assisted shoulder range of motion exercises should start immediately post-op. Early motion helps prevent that dreaded stiffness. Think gentle pendulums, pulley exercises, wall climbs. Muscle strengthening, Focusing on the cuff and scapula muscles usually starts at 6 to 12 weeks, depending on progress and pain. Light office work can often resume immediately. Moderate labor may be 6 to 12 weeks. Heavy overhead stuff
And if
lasts.
there was a cuff repair?
If a rotator cuff repair was involved, rehab is necessarily more conservative to protect the repair while it heals. Typically, a shoulder abduction brace or sling is used for about 4 to 6 weeks to immobilize and protect the repair, reducing tension. During this initial phase, it's all about protecting the repair. Gradual passive range of motion usually starts immediately, but within controlled, protected arcs, guided by the surgeon's specific instructions. Active range of motion comes later, usually after 4 or 6 weeks, introduced cautiously. Muscle strengthening is delayed further, generally starting 8 to 12 weeks post-op. And the progression depends heavily on the tear size, tissue quality, surgeon's assessment. Full return to sport or heavy lifting can take 6-12 months easily.
And setting expectations. That sounds crucial.
Perhaps one of the most crucial aspects, and often underestimated. Many patients see surgery as a quick fix, expecting immediate relief. It's vital to inform them clinical improvement is often not immediate. While the acute sharp pain might resolve quickly, complete recovery resolution of all residual soreness, stiffness can take 6 months or even longer, especially if a repair was done.
6 months or more?
Yes. Patients should be prepared for intermittent pain, possibly persisting for up to 2 years or more post-surgery. This needs clear communication before the operation to manage expectations and reduce frustration during what can feel like a long recovery. The tendon needs time to remodel and heal. Some residual sensitivity is normal, emphasizing continuous follow-up for pain control, monitoring for recurrence, and crucially, adherence to the rehab program that's essential for the best long-term outcomes.
Thank you. That sets a very clear roadmap for managing recovery and expectations. We've covered a tremendous amount of ground today, from the microscopic origins right through to surgical management and beyond. So, to recap briefly, calcific tendonitis of the shoulder is common, often intensely painful and complex. Our understanding of its pathophysiology has evolved. It's not just degeneration, but a dynamic cell-mediated process, perhaps a failed healing response involving stem cells and molecular pathways. We've explored diagnostics. X-rays as the gold standard, hinting at consistency, ultrasound for localization, activity, and guiding procedures, MRI for concomitant issues. And we've navigated treatments. Conservative care as the cornerstone, NSAIDs, physio. Minimally invasive options like barbotage and ESWT, tailored to phase and deposit type. And finally, surgical decompression for refractory cases, understanding the nuances of cuff repair and acromioplasty. The key message: tailored management based on phase and characteristics. As our understanding deepens, especially around the cellular and genetic side, it raises an important question for you, our listener. How might this evolving knowledge fundamentally revolutionize our prevention strategies and the development of truly targeted biological interventions in the coming years? What new insights might genetic screening or novel molecular therapies, perhaps even gene therapies, unlock for managing this? Could they potentially make barbotage and surgery a thing of the past one day? Something to think about. If you found this deep dive valuable, please do consider rating and sharing it with your colleagues. Thank you for joining us on Deep Dive Ortho.